This is insertion day. Since the last film where we saw festooning and preparing our denture pattern, we have processed the dentures. When the dentures come back from the laboratory to you, or if you process them, they should always be stored in 100% humidity. And in this particular case, my usual bit is I put them in a little plastic bag and put a few drops of water in it so that we have 100% humidity. And I leave them stored in water like this until insertion day. First of all, we have made some cast to use as what we call remount cast. And all we've done is after the dentures are finished, we've made a little patty of a thick mix of stone and set the denture on it just enough to pick up all of the periphery. And as you can see, this denture will fit accurately back onto that cast, and we can use that as an aid to help us remount the dentures on the articulator in order to perfect the occlusion. We already have the maxillary cast, remount cast, mounted back on the articulator. We did that by means of a device that we used before the dentures were processed, in that we took a mounting ring and put it to the bottom member of the articulator, and then we took a paper cup and cut the bottom out of it just to make a cylinder that extended up to about the level of the occlusal surfaces of the teeth before we disassembled our mounting now. And we filled that full of plaster and closed the wax denture before it was processed into that. And as you can see, it has an imprint of the occlusal surfaces of the teeth into that plaster. Now after we made remount cast, after finishing them, we could set that denture into that plaster index that we made, and we can assemble the maxillary denture to that, the maxillary remount cast to that, and we can plaster that maxillary cast in place and have that all ready before the patient comes, which is what we've done. Now in order to remount these dentures on the articulator, what we can do is we can remove the plaster mounting, or this plaster index that we made. We call this a Dixie cup transfer. We can remove that, put a new ring onto the mandibular member, the lower member of the articulator, and now with a new centric relation record, we can orient this mandibular denture to the maxillary denture and plaster it in place on the articulator after we get a new centric relation record, and have it mounted back on the articulator so that we can perfect the occlusion before we deliver the dentures. Use a little pressure indicator paste, so-called PIP. We get this from the dispensary, dispensed in a little plastic pill cup, and it doesn't take very much of it. And we can use what's known as an acid brush, which is a very cheap type of brush, throwaway brush. And what we can do with this is we can paint the inside, after we dry this material, the denture base material off, we dry it with a paper towel, and now we can paint the inside of our denture with this material that's called pressure indicator paste. And we'll need a lot of it, just a light coating. And we're going to paint the entire inside of the maxillary denture. I like to paint it keeping the brush strokes all parallel to the periphery or the occlusal plane. And the reason for that is when we're looking for pressure on it, if you have your brush strokes all in the same direction, it makes it a lot easier to read the pressure, if there is pressure on the inside of the denture. And so all we're going to do is to rotate this denture into the mouth and seat it gently and see if we can put some pressure on it. Does that hurt any place to do that?
Not at all.
Not at all, okay. And then we can remove that and see if we have any pressure. And yes, we do have 2 pressure points that I can see, even though he was not complaining of pressure. We have 2 pressure spots. And let me point those out. We have one on the right side in the tuberosity area right there. You can see it very plainly, a pressure spot. And I think if we go to Mr. Poor's mouth and feel in that area, we'll feel a little bump. Yes, we do. You can't see that on there, but there is a little bump right in the area where this, a hard bump in the mouth, a little hard knot of bone, right where you see that little spot. The other thing we see is in the mid-palatal suture, we see a pressure area right in the mid-palatal suture. The significance of this is you will not, as long as you have pressure in the mid-palatal suture area like this, you will not get as good a retention as you will as if you, after it has been relieved, because this keeps the denture from seating all the way. And as long as it keeps it from seating all the way, you will not have real good retention. So what we're going to do is we're going to relieve this area, and then try our pressure indicator paste again. Now we're going to take our denture now, and in the area where we see these spots, this pressure spot, there's one right here, we're just going to take some of that off with a burr. And relieve the area where we saw the pressure. And we're going to also relieve this mid-palatal suture area where obviously there is a pressure spot. Thank you. And after you relieve those, make sure you get rid of the chips from grinding on it. And don't leave those on the inside of the denture. Get rid of the chips as much as you can. Then take your brush once again and paint up the areas where you smeared the material and ground on it, and get it back to that nice brush stroke type of surface of the pressure indicator paste, and then we'll seat that in the patient's mouth once again. Now, even though it didn't hurt before, we detected there was a couple of little pressure areas, so we'll see if we got them this time by placing some pressure on them. And yes, we got them. You can see in the mid-palatal suture that that pressure spot is no longer there, and you can see in the area here where we had the little hard spot of spicula bone sticking out that you could palpate in the mouth, and we had the pressure spot here. That's gone now. That will clean the pressure indicator paste off of the denture and get it back to its normal, back to its original surface. Just clean it up. So for the mandibular denture now, in this mandibular denture, we've put into this denture what's known as a Novus liner. In other words, it has a soft liner in it. The brand name of this particular liner that we've used is called Novus. This is a resilient type of material that's sort of spongy in nature. We use this a fair amount on patients who have debilitated ridges and we think might have some difficulty in adjusting to pressure to the dentures. Now what we're going to do is we're going to do just like we did with the maxillary denture. We're going to take our pressure indicator paste and we're going to smear it with horizontal brush marks over the internal surface now of the denture. And we're going to do this all the way around, just like we did with the maxillary denture. And after we get it painted real well with the pressure indicator paste, just like we did with the maxillary, without the influence of the opposing denture now, just with finger pressure, we're going to seat this in the patient's mouth. Put your tongue up on top of it, Mr. Poor. That's it. Just relax now. And just put a fair amount of pressure right on the occlusal surfaces. Does that hurt any? No, not at all. Okay. And then we're going to take that out and see if we have any pressure spots. The only thing that I see is a long crest of ridge, and I'm not sure that we can do anything about that at this point, so I think we're going to leave that alone. I see no obvious pressure spots that I would be concerned is going to cause him a tremendous amount of discomfort. So we'll clean the lower up at this point now. In other words, get all of our pressure indicator paste off of the denture base material. once we have this cleaned, we're going to go to the mouth and check the occlusion and check generally to see how well the dentures fit. Put them both in the mouth. Seat it very well. Put the lower in the mouth. And now I want you to let your jaw just drift back and close on your back teeth, Mr. Poor. Very good. Open and close a couple of times. Very good. The occlusion appears to be very close. It appears as though we have done a pretty good job on jaw relations and that we have relatively even pressures all the way around. But that's only a perception, because with those dentures sitting, new dentures sitting on the tissue, when you have them closed, you cannot see and actually feel if there's even pressures all the way around. The only thing that you really can do is guesstimate that yes, it's close. In order to see whether or not you really have even pressures with it, what we need to do is to make new jaw relation records and put those dentures back on the articulator, and with the use of some articulating paper or film of some sort, see if we're getting even contact. We're going to make a new record of centric relation by placing compound onto the occlusal surfaces in the same manner that we did for the original records that we made, and in the same manner that we did when we were border molding, by heating the compound and placing it over the occlusal surfaces of the maxillary, getting the compound very, very soft, and then letting our patient close into that with the dentures in the mouth, close into that compound, but not all the way to the point to where they touch. Right now we don't have a pinpoint flame because the wick's standing up just a little high, so we'll squeeze that wick down some till we get a pinpoint flame, about like so. Now we're going to use compound and heat the compound in the Bunsen burner, and I like to heat it directly in the Bunsen burner for this particular procedure so I can get it super hot. And I'm going to smear that compound onto the occlusal surfaces of the mandibular denture from the premolars through all the posterior teeth, premolars and molars. And I don't want a lot of compound on there, maybe a millimeter, millimeter and a half layer in thickness of compound, about like so. I'm going to do that on both sides. And get a little layer of compound onto the occlusal surfaces. Wet it in the water bath, and with some wet fingers now we can build that compound up into a little sharp point. And with the compound built up into a sharp point, we take our torch and just superheat the surface of that so that that compound is conditioned to be as soft as we can possibly get it. Then we're going to temper it for 10 or 15, 5 or 10 seconds or so in the water bath. And now, Mr. Poor, I don't want you to close very fast and jerky. I want you to just pay attention to what I tell you and do very slowly. I want you to put the tip of your tongue as far back as it'll go. That's it. And I want you to close very slowly, and don't feel for it, just close straight up, right in the middle. Feel. That's it. Go just a little more. Mash it a little more. Right there. Now what we've done is we've had him close in centric relation, open, but we purposely did not want him to close far enough to the teeth would touch. We wanted all of this to be in compound without any penetration of the compound to the point to where the teeth would touch. So now that we've done that, we can chill this material and go back to the mouth once again. And if we had the perfect record when we have him close this time, he will go to exactly to that position without having to shift his jaw. All right, pull the tongue way back and close again. Straight up, don't feel for it, just close. And there it is, seems to be right on the button. Everything fits perfectly as it's supposed to. Open now. Now that we have what we think is a pressure-free centric relation record, at this point we can assemble everything and plaster this to the articulator. Would expect that this record would be much more accurate than any of our preliminary records that we made on temporary basis. So we're going to utilize this record now, and we're going to assemble the dentures along with their remount cast. We're going to assemble it onto the articulator. Okay. The question is if we had posterior interferences, when we assemble this, get this record, and we look here or here, we would see that denture base from the lower denture would be touching denture base from the upper denture, and that would be unacceptable. At that point, before you could get a record, you would have to relieve those interferences and get them to where there's an absolute clearance before you could get a record. But this one has no posterior interferences, so we can assemble it as it is. Sometimes you have to sticky wax these in place, and sometimes you don't. So we have to see how well these do by just assembling it and see if they're stable. Yes, they're very stable, just like that. So what we can do now is plaster those in place, and then we'll be ready to grind the occlusion and to perfect the occlusion. And what we're going to do is we're going to make a mix of quickset plaster and plaster that mandibular denture to the articulator. I usually like to use what I call a decant method. In other words, put material into the bowl till there's a fair amount of dry material build up in the middle of it, and then decant the excess water that's around the side of it off. Just decant it off, and that generally will give you a pretty decent mix of plaster for mounting purposes as far as its consistency. And this is about a little heavier than sour cream, and that's generally considered a fairly decent mix for mounting purposes. Remember also, as you're mounting, to make sure that you fill the dovetails and the recesses into the mounting ring with the plaster so it doesn't fall off on you. This is one procedure I can't do with a glove on, so I want to remove the gloves to finish the plastering job now. So all I'm doing is filling in between the plaster ring, or the ring, the mounting ring, and the base of the cast. And then you can take a wet finger, if you get to this early enough, and smooth that up till it's at least somewhat presentable. And just with a wet finger, smooth the plaster. And in areas where you can't get to it with a wet finger, such as up here by the mounting table, if you'll take a knife, you can smooth that off. And the material at this point has reached a fairly good set, to the point that we would feel safe in separating these now. And we can do that simply by opening up the articulator. We can remove the dentures from their mounting bases, remove all of the recording medium. In this case we used compound, and by the way, in removing compound for a denture, never heat it to remove it. Always chill it. If it isn't very, very hard, it will not flake off very well. And if it doesn't flake off, chill the material to get it off of there. Chill it, and then it will flake off. If you heat it, it will just smear. Articulator, and we would expect that the occlusion would be open now when we close this, because there was a recording medium there. And now, as we can see, they don't touch all the way at this point. A little piece of debris there. So what we do is loosen the incisal guide pin and get the guide pin up out of the way, because at this point that incisal guide pin does us no good at all. And we can see now that we have the teeth back into occlusion, and with this point we don't know if that occlusion is good or not. I would venture to say that there are some imperfections in it. So the material that I like to use in grinding in the occlusion on a set of dentures is Accu-film 2. That is a film over a little plastic sheet. And that's the separator between them there. So here's the material. And as you can see, Accu-film 2 has red on one side and black on the other. And so what we're going to do is to use the Accu-film now to tell us whether or not we have good occlusion. And we do it by just tapping it and seeing where our high contacts are. And when we analyze what we have here, we see that we have a contact on a premolar, on the buccal cusp of a premolar right there, and we have a contact to the lingual cusp of the maxillary molar right there. This maxillary molar is contacting right there on the mandibular molar. This buccal cusp of the maxillary premolar is contacting the mandibular premolar right there. So I want to grind this cusp here, and I want to grind that point there. And we'll grind this one here. And now we can check that once again with the articulating ribbon. And now we're getting more contacts than we had before. At this point we're laid an instrument down, there it is. We're getting contact here again. We're picking up contact on the lingual cusp of this upper molar now, and the lingual cusp of these upper molars here. But we're also picking up a little interference back here. Let's see what that amounts to. Now that we have the new record, when we close this all the way into occlusion, we're getting a little interference right there. So we're going to have to correct that. We'll start with that maxillary denture, correcting the interference on the base material. Now let's see if we're beginning to get clearance now of the tuberosity and retromolar pad coverage area. Just starting to get clearance of it, but I still think we need some more grinding on it because it's very close back there. So we're going to grind on that a little more. In the process of grinding occlusion, you check those tuberosity to retromolar pad areas to make sure that as you grind occlusion and the vertical dimension of occlusion is lessened because you're grinding on the occlusion, that as you do that, you don't create an interference. Now, and this instrument will pass through here quite readily now, so we've got a good 2 millimeters of clearance there between the retromolar pad coverage and the tuberosity coverage of the denture. Now, our articulating marks that we get for occlusion now should be truer than they were than what we had when we had the interference. As we can see, we still have a buccal cusp interference on the maxillary here. And all the others are on lingual or on central groove here and here on the mandibular. As you can see, we have some marks here and we have some marks here. So those interferences and occlusion are here. and here. We'll put them back on the articulator again. And check them with the articulating paper, with the Accu-film. And as we can see, we're beginning to get more and more contacts. We're getting contacts here and here, 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 and here. And on the other side, we're getting contacts here, here, and here. That's here, here, and here. So keeping in mind that you want to grind the buccal cusp of the upper and the central groove or lower cusp, or lingual cusp of the lower, we will grind that one cusp on the upper, and the remainder of the grinding will be done on the lower, into the central groove and lingual cusp. We're beginning to spread our contact out quite evenly now. It's not quite all the way, but it's almost there. You can see we've got contact here, here, and here, with a very slight contact right there. We have contacts here, here, and here, and no buccal cusp contacts. So I want to grind all lower grooves except this little area right there. That area should coincide to that one, and it does. So I want to grind this lingual or occlusal slope of the buccal cusp on this maxillary first molar, and the rest of it, the grinding I want to do on the mandibular arch to deepen the groove and reduce lingual cusp in order to achieve the contact we're after. So we're grinding central groove and lingual cusp on the lower, and buccal cusp on the upper. And then we'll put them back onto the articulator again. And see what how our contacts are coming out. We're doing pretty good. We're getting contact here, and here, and here, and here, 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 and here. We're getting a few buccal cusp contacts right there and right there. So right now, the only thing I'm really interested in is eliminating these buccal cusp contacts. That's here and here. And then let's see what they look like. The mere thickness of this film of articulating paper, regardless of how thin it is, that thickness of it can give you some false readings on the teeth. And in order to see if those readings are false or true readings, what you can do is use shim stock. Now, shim stock is a little piece of foil that is very, very thin, and it's cut in strips. And we can use that foil to see how many of these marks are true. We see we're getting a small mark here and a heavy mark there, a small mark, a small mark. Over here we've got a mark there, some heavier marks right through here. Now, I don't know if I had to grind some of these, which ones of those marks I really would like to grind. But the way I can tell which ones I would like to grind is with the use of some shim stock. You can place it between the occlusal surfaces of the teeth and judge how much pressure it takes to pull it through. Now, there is contact of those molars right there, but it doesn't take a lot of pressure to pull it through. The same is true there. The same is true there. It's pretty well even all up and down this entire occlusal scheme on the right side, in that the amount of pressure it takes to pull that shim stock through is pretty even. Now, let's see what we get on the other side. A little pressure, just about even. I judge that I have one mark that's slightly heavier than the others, and that is in the first molar region on this one side where I see this one mark that's a little bit heavier than the rest of them. This particular mark right there, and when I pull the shim stock through, is a little heavier than the rest. The rest of them are about even, so I'm going to relieve that little mark right there, and then let's see how the shim stock feels to us. We'll put the shim stock, put it back onto the articulator, and use our shim stock to see if that pull is evened up any from where it was. Now it's a little heavier on the molar now than it was a minute ago. It's about the same where I just ground it. It's much more even up and down that entire side now. It probably is more even on the other side also, yes. Takes about the same amount of pull to pull that shim stock through now in all areas of our posterior scheme, which tends to indicate to us that we have done about as much as we can do as far as the centric relation contacts are concerned. We have one other thing that we need to do before we're ready to deliver the dentures, and that is to check the lateral motions. We do that by opening up the condyle, by loosening the little knurled brass knob so that this condyle will move freely. Do the same on the other side. Open it up till it will move freely. And now what we should see is we should be maintaining contact with the lingual cusp of the maxillary denture, contacting into the central groove of the mandibular denture, and it should maintain contact as we go into lateral motion, and it should have balancing contacts on the opposite side. It should be maintaining contact of the lingual cusp of the maxillary with the lingual cusp of the mandibular as it goes into that motion. As we come around to the opposite side, we should see the same thing, maintaining lingual contacts of the maxillary teeth with the lingual cusp of the mandibular teeth. That's in working. Simultaneous with that, on the opposite side, we should be maintaining lingual cusp of the maxillary with the buccal cusp of the mandibular as non-working or balancing contacts. This seems to be in pretty good shape along that line. I need to remove the dentures now from the articulator, and I need to take those dentures back to the laboratory and polish those areas that I have ground on. We're ready to insert the dentures and give our patient their instructions. Always rinse the dentures, make sure they're nice and moist. And now we're going to place them in the mouth. And we will do one last check of occlusion to see that the grinding that we did is even the forces. Now I want you to close on my fingers, Mr. Poor, and hard. I want you to see how hard you can bite them. That's good. Now open just a little bit. I want you to close on nothing but your back teeth. Very good, solid as can be. Now slide your teeth, keep them together. That's it. Now I want you to just slide them round and round for me. Feel pretty stable to you now? Mm-hmm.
Yes.
Okay. At this point, we're ready to instruct our patient as to the do's and don'ts and how to care for things and how to maintain the dentures in the best manner possible. First of all, we'll be seeing our patient tomorrow for a 24-hour adjustment. That's in order for us to take care of any major problems that might arise, take care of them early in the adjustment phase so that he doesn't suffer with them. Usually after the 24-hour adjustment, we can space the adjustment period out for several days before we adjust them again, and average should be in the neighborhood of 4 or 5 adjustments, and you'll have them pretty comfortable by that time. First of all, let's start with your speech, Mr. Poor. I know that you're used to an old set of dentures that we have here, that you wore in here today, and the contour of those dentures is quite different from the contour of the dentures that we're placing in your mouth today. And across the palate of it, the contour is different. And down around the lower where the tongue lies, down here the contour is different. And as a consequence, since that contour is different, your speech is going to be slurred, particularly the S sounds, okay? You may tend to have an airy or whistle type sound with those dentures right at first. This is due to the change in contour, and your tongue hasn't learned yet those new contours and learned how to control the airflow that goes across your tongue to make sounds. So generally, within 2 weeks, that will subside and you'll be back to talking normal with them again. We know that it is extremely rare that you would have no soreness at all with them. That's extremely rare that that would occur. I hope it does, but I expect there will be some soreness, okay? That's why we have adjustments. That is our responsibility to adjust them. And by all means, do not take it into your own hands and try to adjust them yourself. But your mouth needs a rest of about 8 hours out of every 24 hours. And for that reason, we would like you, when you sleep, not to have your dentures in your mouth. So I would like you to start out, even the first day, first night, take the dentures out, place them in a container of water or just room temperature water or cold water, out of the cold water tap, leave them overnight, and then the next morning scrub them up and put them back in your mouth, okay? That's so that those tissues will get a rest. What keeps a set of dentures clean is your diligence of how well you clean them after every time you eat. This is a denture brush, which we can give you, okay? It's a good stiff brush, and whatever you'd use on your face and hands is good to use on it, but when you get soapy water on them, they're going to get slick. So what you should do is run your sink full of water and scrub them directly over the water, so if you drop them, because they're slick, and you drop them, they're not going to drop in the sink and break, okay? Some people like to say that their dentures taste better to them or smell better to them or what have you if they use some of these commercial soaks, such as Polydent or Efferdent. Okay, what I recommend that if you want to use those, it's okay. They won't hurt anything. But when you soak them overnight, you can soak them in those soaks, such as Polydent or Efferdent, when you soak them overnight. The next morning, scrub them up well, rinse them well before you put them back in your mouth, okay? Those materials do not remove all of the food debris. It's the brush and soapy water that takes the food debris off of there and keeps them from staining up on you. And by all means, do not use Clorox on them, okay? Clorox will bleach that stuff out, and it has some adverse effects to it that I don't think we want to deal with, okay? I would not expect you to be able to go home and eat with that set of dentures tonight, even as well as you ate with your old dentures. The reason why is you haven't gotten used to them yet. You don't know what the pattern is of how you go about chewing yet. That comes about by your confidence in using them and getting used to the feel of the new dentures as opposed to the old dentures, okay? So what you need to do is to start with foods that are relatively easy to chew. Vegetables, things that do not have a lot of cellulose in them. As an example, celery and lettuce have a lot of cellulose in them. They're very difficult for you to chew. So don't start out with that sort of thing. Start out with things like well-cooked vegetables such as green beans, potatoes, carrots, things of this nature that require a little bit of chewing, but by the same token don't have a lot of cellulose in them so that they're hard to chew, okay? And I would like you to take half the size bite that you normally would take at first. And as you go along, you can start increasing the consistency of what you eat and the size of the bite until after a fairly short period of time you should be eating what would be normal for you. Meats. Let's get on to from the vegetable bit to meats. Start out with meats that are ground meats that are broiled or baked but not fried, okay? Such as meatloaf, something of that nature. Things that are pretty easy to chew that are not even ground is fish, white meat of turkey or chicken. Those are things that are fairly easy to chew and do not require grinding before you can eat them. Your friends may look at them and say things look different, okay? Sometimes friends can be cruel because they'll tease you about them. I've had that to happen too with patients. So don't pay too much attention to what your friends say at first, okay? Give them a week or two to get used to things and then see what they have to say about them, okay? Oh, one thing that I did not mention to you that I should mention to you is that use no medicines on the inside of them, okay? If you get a denture sore, all these things that you see advertised, these medicines, they don't cure anything. They will relieve the pain for a few minutes because it's an analgesic, an anesthetic ointment is what those things are, but they don't cure anything. A sore on the inside, your gums getting sore from a denture is like having a nail in your shoe, okay? And as long as you wear that shoe with a nail in it, your foot's going to be sore. So the idea is let us take the nail out of it, okay? So if there's something wrong with them causing them to be sore, then that's our job, is to take care of them. I personally am very gratified as to what I see, as to the result. Whether or not you will be or not, that remains to be seen. So we'll let you make those judgments for yourself.